Yeah, very good morning, dear students. Hope you all are in good health. Stay indoors and stay safe and stay healthy. I think it's the first time in the history of mankind that we have been forced to be indoors, and I think it's the first time we are planning online classes for you. So please be careful. Please maintain distance. Self distancing is the best way to save our lives and to fight out this pandemic of COVID 19. This brief introduction, I would like to go surf into the pharmacology lecture, that is malaria. The topic of discussion today is malaria, the treatment of malaria. As you very well know, malaria, it is a disease caused by a protozoan, that is the plasmodia, the protozoan. It mainly presents with high grade fever associated with chills, rigors, anemia, splenomegaly, and various other symptoms. Now, this malaria, it is very rampant in countries like Asia and Africa, and it's also present in India. And we do have many endemic areas which are associated with malaria. Like, for example, if you look into Vishakhapatnam, we have a place called Paderu, where it's highly endemic there, and parts of Vijayawada, the coastal Andhra, and of course, it is present everywhere in the country. And as you know, this particular disease is transmitted by a vector, which is a mosquito. That's the female Anopheles mosquito. So, my talk today uh, will be on these contents. So, at the end of this talk, you'll be in a position to know the brief introduction, the history, what are the mode of infection and transmission, the clinical manifestations of malaria, a bit about diagnosis, and the various drugs which are used for tackling the various presentations of malaria. This is how my lecture goes. Now, when you talk about malaria, you know that malaria, it is the word derived from Italy, the Italian word, that is mal and aria, means bad air. It is caused due to the bite of a vector. As I already told you, it is none other than the female Anopheles mosquito, which mainly harbors the protozoan, that's the plasmodia. And as you know, this Anopheles means worthless. So this is how the name was coined for this mosquito, which is harboring plasmodia causing malaria. Anopheles means worthless. And apart from that, little bit of a history regarding the manifestation of the disease. So as you are very well aware regarding Hippocrates, who's a physician and is regarded as father of medicine, who was the first to describe the manifestations of malaria. And the discovery of the parasite in mosquitoes was done none other than Sir Ronald Ross, who is a British scientist, for which he has been conferred with the Nobel Prize in 1962. Apart from that, In 1907, Alphonse Laverne received the Nobel Prize for his work in which he has showed that the parasite was found in the human blood. So, the parasite was found in the human blood was noticed by Alphonse Laverne, for which he was conferred the Nobel Prize. When you go back to the history regarding the treatment aspect of malaria in the early days, so way back in the 17th century, uh, this particular disease was treated from an extract of a bark of cinchona. There is a cinchona alkaloid. So the bark of cinchona tree of Peru, it was initially used to cure the fevers due to malaria. And in 1820s and up to even 1940s, quinine, which was isolated from the cinchona bark, was the mainstay for the treatment of malaria. And later on came mepacrin, and this mepacrin was a drug which was mainly produced in Germany in 1926, and this was a drug which was extensively used to treat malaria during the World War II. Later on, the chloroquine, which is the miracle drug, the first company to launch this drug was in Germany by pharmaceutical company by name Roche, and it is manufactured by the name Resocin. And you know, this Resocin is even available today. So we use Resocin, that is your chloroquine sulfate, 250 milligram chloroquine, which consists of 150 milligram base by the name Resocin. This is a unique company, the pioneer company, pharmaceutical company. Roche has launched this chloroquine in the year 1934. Later on, proguanil, pyrimethamine, and so on and so forth have come into the market for treating the various forms of malaria. This is regarding the brief history about the treatment aspects of malaria in the older days, or the recent or the earlier days. Now when you talk about this parasite, as I told you, this parasite, which is the Plasmodia species, which is a protozoan, the predominant species causing various types of malaria are, they're mainly the four species, that's Plasmodium vivax, Plasmodium falciparum, Plasmodium ovale, Malaria. Out of these four, two are very common, that is your Plasmodium vivax and Plasmodium falciparum. Malaria is very common, but we don't have much of ovale and Malaria. But apart from these, there are two other species of malaria or Plasmodia, which are called as Plasmodium knowlesi and Plasmodium cynomolgei. So these are the two species which are the rare species of Plasmodium. Now, when you talk about the disease globally, nearly 50% of the cases across the world is caused by Plasmodium falciparum. And apart from that, when you look into the life cycle of this malarial parasite, as I already told you that the mosquito being the vector, it is the definitive host of Plasmodia, and the intermediate host being the human or the man. So when you talk about this cycle of malarial parasite, the life cycle is divided into two. One is the sexual cycle, it mainly occurs in the mosquito, and the mosquito is the definitive host, and the incubation period of this parasite is around 9 to 14 days. When you talk about the life cycle of Plasmodia, in the humans. It is called as asexual cycle, where I told you man is the intermediate host. And the infective form of plasmodia is the sporozoite. Is the sporozoite. Now, when I talk about this life cycle, see this Anopheles, female Anopheles mosquito, which is loaded with plasmodia when it bites the humans. So, when it bites the humans, it releases the sporozoites, and these sporozoites, they initially enter the human host after the bite, and they reach the liver. So the entry of the sporozoites in the tissues till the liver, it is called as pre-erythrocytic stage. Then what happens in the liver? These sporozoites, they come out of the liver. There are various stages which occur in the liver. They come out of the liver, enter the blood vessels, and then invade the blood cells, that is the RBC. So this stage, it is called as erythrocytic stage. So we have a pre-erythrocytic stage, the erythrocytic stage, and then becomes the sexual developmental stage, that is the development of gametes occur. Okay, and in this erythrocytic stage, this parasite will get converted into, the sporozoites will get converted into merozoites. So merozoites in turn into the RBC to form a signet ring stage. Then it enters into another stage which is called as a trophozoite, and then a zygont is formed. After the formation of zygont, these merozoites are again released into the blood. Okay, and next time when the mosquito it bites, it will take up these merozoites. So this is how the life cycle of the plasmodia occurs, both in the mosquito and the human. Now, when I talk about the symptomatology of malaria, what are the symptoms of malaria? So, the malarial patient, he mainly presents with an headache. There's a central or the affecting the brain, that is the headache. Then the systemic symptoms like fever associated with chills and rigors. Especially the fever and rigors occur when there is a release of merozoites from the RBC into the blood. This is where the fever and chills and rigors will occur. Apart from that, there is a fatigability and muscular pain occurs. Especially the pain occurs in the lower back or in the back. Then the fever is also associated with chills and sweating. And when you talk about the respiratory system, the manifestations of the dry cough. And most of the times when you palpate the spleen, there's enlargement of the spleen, that is splenomegaly. So splenomegaly is the main. So definitely we have to palpate the spleen. Okay, so whenever there's a splenic enlargement, so we have to suspect of malaria. Of course, there are various conditions where there's massive splenic enlargement which occurs in Kala Azar and so on and so forth. Then the associated symptoms like nausea and vomiting may also occur. So here, malaria, when you talk about falciparum malaria, It is called as the brain fever, or the, the malaria which occurs the brain, okay, or the cerebral malaria. Falciparum malaria is also called as cerebral malaria. It is also called as black water fever, right? Because of hemolysis, there's the urine is looks black in color, black water fever. So these are few signs and symptoms of malaria. The clinical features of cerebral malaria, especially when there's involvement of the brain, there is a diffuse symmetric encephalopathy, there's altered mental status followed by convulsions, coma and death. Apart from that, prior to that, if you go for a fundoscopic examination, there might be retinal hemorrhages, papilledema, and associated hypoglycemic symptoms. This cerebral malaria also manifests with acidosis, non-cardiogenic pulmonary edema, and renal impairment. And when you look into the blood picture, there is normocytic normochromic anemia, thrombocytopenia, there is elevated prothrombin time, and activated partial thromboplastin time. So these are the alarming symptoms or features of cerebral malaria. So as I told you, 50% of the cases globally are due to cerebral malaria. When you talk about the fevers, because generally, as I told you, there are various species of plasmodia present with different types of fevers, especially malarial fevers. When I talk about Plasmodium vivax, which is very common, this has a mild nature. It is mild in onset and a mild type of fever, and this type of fever is called as benign tertian malaria. The malaria due to vivax is benign tertian malaria. When I talk about falciparum, Plasmodium falciparum, it is called as fulminant malaria or malignant tertian malaria. Then Plasmodium ovale and Plasmodium malariae, they are also mild in nature and they are benign quartan malaria. They are called as benign quartan malaria. They are very rare in India. Now when I talk about the complications or the chronic complications of malaria, quartan malaria is associated with nephropathy, and it mostly manifests with nephrotic syndrome, especially with Plasmodium malariae, and it is also associated with focal segmental glomerulosclerosis. Which one? Quartan malaria, nephropathy, and focal segmental glomerulosclerosis due to Plasmodium malariae. Then in chronic complications, we do have tropical splenomegaly, where there's massive splenomegaly, hepatomegaly, elevated immunoglobulin M IgM, and hepatic sinusoidal lymphocytosis, peripheral lymphocytosis. Then increased incidence of EBV, that is Epstein-Barr virus, and Burkitt's lymphoma is also one of the chronic complications of malaria. So when malaria is associated with Epstein-Barr virus infection, it may result in development of Burkitt's lymphoma, or EBV and Burkitt's lymphoma are the chronic complications of malaria. Apart from that, when you look at the host responses due to this malaria, the host means the humans, they try to cause splenic clearance. That means a removal of both parasitized and non-parasitized erythrocytes. So this is called as splenic clearance. Not only that, in the host response to the parasite, there is activation of macrophages by substances released due to rupture of sisons, and this will cause both the humoral and cell-mediated immunity to get activated. And not only that, the host response is a protective response in patients, in people who do have G6PD deficiency or G6PD. Not only that, sickle cell anemia, ovalocytosis and thalassemia, the host response is a protective response to the parasite. And in addition to this, the persons who have a Duffy negative blood group are also having protective activity against Plasmodium vivax. Now, after looking into the introduction, the history of drugs, the signs and symptoms of malaria, then the cycle of malarial parasite, the manifestations of various malarias, the chronic manifestations. Now we will go into the drugs which are used for the treatment of malaria, the pharmacological or pharmacologist perspective. When I talk about the drugs used in the treatment of malaria, we do classify the drugs based on chemical structure. Number one, based on chemical structure is the first classification. In this we do have cinchoalkaloids. As I told you, these cinchoalkaloids were also used way back in 17th century for the treatment of malaria. So the cinchoalkaloids also have a role to play even today. The drugs available in this group are the quinine and quinidine. The quinidine, it is mainly used in United States of America, whereas quinine we do use in India too. And the second classification or the second group, depending on the chemical structure, are quinolone derivatives. Quinolone derivatives. In this we have 4-aminoquinolones. So this is a main class of drugs, quinolone derivatives, that is 4-aminoquinolones. In this we have drugs like chloroquine, amodiaquine, pyronaridine. Chloroquine, amodiaquine, pyronaridine. These are the drugs which are categorized as quinolone derivatives, that is 4-aminoquinolone. Then we do have another group in quinolone derivatives, 8-aminoquinolone derivatives. The drugs in these category are the primaquine, bulaquine, tafenoquine and etaquine. Primaquine, bulaquine, tafenoquine and etaquine. They are present in 8-aminoquinolones. Apart from that, we have quinoline methanol derivative or phenanthrene group of drugs. Quinoline methanol, it is quinoline methanol derivative. We have mefloquine. Apart from that, depending upon the structure, chemical structure, we do have another category, that is phenanthrene derivatives. And in this phenanthrene derivatives, the drugs are halofantrine, lumefantrine, etc. Halofantrine, lumefantrine. Then we have another category, that is naphthoquinone derivatives. In chemical derivative, chemical structure derivatives, we have one drug available, naphthoquinone, that is atovaquone. Atovaquone belongs to naphthoquinone derivative. Then the third category is the antifolates. In this antifolates, we do have two category of drugs. One is the biguanides and diaminopyrimidine derivatives. Biguanides, proguanyl. So please remember, biguanides are a group of drugs or a category of drugs which are also used in the treatment of diabetes, especially type 2 diabetes. So biguanide like metformin, fenformin. But here in the treatment of malaria as an antifolate, the biguanide, we use proguanyl. So biguanides for type 2 diabetes mellitus is metformin, fenformin. Biguanide used as antifolates in the treatment of malaria is proguanyl. Apart from that, we have another category in antifolates, diaminopyrimidine. So in this we do have pyrimethamine. So this pyrimethamine is used in combination of sulfonamides. It is used in the combination of sulfonamides for the treatment of malaria. For example, we do combine pyrimethamine and sulfadoxine. Pyrimethamine and sulfadoxine. Sulfadoxine is a sulfonamide in the treatment of falciparum resistant malaria. Okay, now we have another category of drugs. They are the derivative compounds, the artemisinin derivatives. Artemisinin derivatives. So these artemisinin derivatives, actually they are derived from a Chinese herb, Jingguasu. The name of the herb is Jingguasu derivatives, or we do call them as artemisinin derivatives. In this also we have a group of drugs, a very important group of drugs, artemisinin compounds, like the artesunate, arteether and artemether. Artesunate, arteether and artemether. So these are the three drugs which are called as Jingguasu derivatives or artemisinin derivatives. Apart from that, we do have another category of drugs. They are called as antimicrobials or antibiotics used in the treatment of malaria. Yeah, definitely they have a role to play in treatment of malaria. The drugs which are used as antimicrobials are tetracyclines, doxycycline and clindamycin and clindamycin. Apart from that, we do have the recent drugs like phosmidomycin, and the vaccines are also tried for the treatment of or prevention of malaria. So where the novel targets exploiting differences in biology of the host and the parasite. So the recent drugs involve phosmidomycin and vaccines or malarial vaccine. So these are the category of drugs available for treatment of malaria. So here these drugs are based on different, like chemical structure is one, then we do have chemical structure like quinolone, antifolates, artemisinin, antimicrobials and so on and so forth. And apart from that, if you talk about the drugs which are classified based on the affected state of the patient, or the drugs which are used in the state of malaria, for example, or the stage of malaria, These drugs are classified as zygenticides. They are classified as zygenticides. Number 2, gametocides. Number 3, sporonticides. 1, zygenticides, gametocides, and sporonticides. So, depending upon or based upon the affected state of malaria, they are classified into 3 types. Number 1, zygenticides. Zygenticides, they are tissue zygenticides. And tissue zygenticides, especially the hepatic zygenticides, the pre-erythrocytic stage, isn't it? So I told you there are 3 stages. Number 1 is pre-erythrocytic stage, that is before the parasite it invades the blood cells or the RBC or the erythrocytes. That is pre-erythrocytic stage. We use the drugs zygenticides, tissue zygenticides, especially the hepatic zygenticides. Here we have 2 types of drugs available. Number 1, primary tissue zygenticides, which act on pre-erythrocytic stage of Plasmodium falciparum. It acts on the pre-erythrocytic state of Plasmodium falciparum. The drugs are proguanil and pyrimethamine. They are 2 drugs, tissue zygenticides, primary tissue zygenticides, proguanil, pyrimethamine. Then we have, in tissue zygenticides, we have secondary tissuezygenticide, that is primaquine. It is a very, very important drug. We have to remember primaquine. This primaquine, it acts on exoerythrocytic zygogony. It mainly acts on exoerythrocytic zygogony. Now, there are another types of zygenticides which are called as erythrocytic zygenticides. So what are these erythrocytic zygenticides? They mainly act by inhibiting the erythrocytic zygones. One of the most important stage of malaria, that is by inhibiting the erythrocytic zygones. Hence, these drugs, they are mainly used in the acute episode of malaria. Why? Whenever there is erythrocytic zygones present, they release into the blood. The RBC get ruptured, released into the blood, and they manifest with acute malarial symptoms like febrile illness. So in this situation, we do use erythrocytic zygenticides, and these erythrocytic zygenticides are also divided into 2 types. One is fast acting zygenticides, slow acting erythrocytic zygenticides. The fast acting erythrocytic zygenticides are chloroquine, amodiaquine, quinine, mefloquine, halofantrine, lumefantrine, and artemisinin derivatives. They are fast acting. What are these drugs? Chloroquine, amodiaquine, quinine, mefloquine, halofantrine, lumefantrine, artemisinin derivatives. So they are fast acting. Now, the second category of erythrocytic zygenticides are slow acting zygenticides. They are proguanil, pyrimethamine, sulfonamides, and tetracyclines. Proguanil, pyrimethamine, sulfonamides, and tetracyclines. Then we have another category of drugs, they are called as gametocides. So these gametocides, The drugs like primaquine is the drug which is a gametocide which can be used in the treatment of all species of plasmodia. All the species of plasmodia, primaquine acts as a gametocide. Apart from that, chloroquine and quinine. Chloroquine and quinine are also used for all the stages or all the types of malarial parasite except Plasmodium falciparum. Now, you have to understand one thing. Whenever there is falciparum malaria, we do give chloroquine along with the radical cure. Okay, so it can be used in the treatment of all types of malaria. Primaquine, all species of plasmodial infection. Chloroquine, quinine, they are used for all the species of plasmodia except Plasmodium falciparum, to be noted. Okay. Now, the next category of drugs are sporonticides. In the sporonticides, the drugs available are proguanil and pyrimethamine. The drugs available are proguanil and pyrimethamine. Now, so this is the classification of drugs depending upon the chemical structure, depending upon the stages of the malarial parasite. Now, when you look into the treatment modality or the objectives of treatment of malaria, the primarily the objectives will be: number one, to prevent a clinical attack. So how do you prevent a clinical attack of malaria? For example, we use drugs as prophylaxis. Why? Suppose we don't have malaria, or I don't have malaria, but still I go to a place where malaria is endemic. There is endemicity of malaria in a particular area. As I told you, I want to go to Visakhapatnam to visit Padiru or Vijayawada and want to stay there for months for some training or some I'm learning some course. So there I have to prevent myself from a clinical attack of malaria. So I need to take a prophylactic course of malaria. Then, so this is a preventive aspect. When you talk about the treatment of clinical attack, this treatment, it is called as a curative aspect or clinical curative aspect in the treatment of malaria. Then the third one objective is to completely eradicate the parasite, okay, from the human body. So how one can completely eradicate the parasite from the human body, because it is present in various stages. So this type of eradication is called as a radical cure. It is called as a radical treatment or radical curative modality in the treatment to completely eradicate a parasite. And this is where the role of primaquine comes. Then not only that, the fourth modality is to cut down the human mosquito transmission. To cut down the human to mosquito or mosquito to human transmission. So we do have to give a gametocidal drugs are also very much useful. So we have four modalities or four objectives in the treatment of malaria. Okay, now when I talk about these objectives, the first objective is the prophylaxis. How do I prevent a malaria? So where we need to go for various vector control measures have to be taken to prevention of malaria by control of vector. So once you want to do a vector control, the transmission of disease from the definitive host to the intermediate host, that chain is broken, the transmission of malaria also comes down. So what we do here, we go for some anti-adult measures. So the vector, that is female Anopheles mosquito, you know where it is bred, the breeding places of female Anopheles mosquito, especially where ditches, ponds, where the water is stagnated, where the sanitation is not proper, on the overhead tanks and our roofs and all. Definitely these are the places where the breeding of mosquitoes occur, and where the sanitation is not proper, the mosquito breeding occurs. So we do have anti-adult measures to be taken or to be implemented. So in this part we mainly focus upon a residual spraying of DDT. So this is actually a neurotoxic. DDT is a neurotoxic, and every 3 months at least indoor spraying has to be done. Apart from that, it has to be sprayed on the surface of the houses. If the DDT resistance occurs, then we have to go for malathion or phenitrophthion. So malathion, phenitrophthion. So I think nowadays we are not using this DDT spray, because this DDT is going to stay for longer and longer periods of time, and it is not very good to the human, or it is going to persist or persistently stay in the environment or in the body also. We don't know how much DDT we have in our bodies. Then apart from this malathion or phenitrophthion spraying, there is certain thing which is called as space application. So the space application of this we call fogging. We do fogging, especially where there's a major anti-epidemic measure. So it is the fogging or space application is taken as a major anti-epidemic measure, as you well know. So we are having an epidemic, that is your coronavirus, COVID-19, and then social distancing is being maintained to break the chain of the viral circulation among the people. Okay. Similarly, in this epidemic, as an epidemic measure, we go for space application or space fogging of malathion or parathion or phenitrophthion. Then there are other anti-adult measures like insecticides in the form of fog or mist using special equipment, and of course the individual protection measures are also used, especially by using the repellents, screens and mosquito nets. Then we do have anti-larval measures. In this anti-larval measures, we do use this larvicides, especially the larvicides like Paris green oiling on the stagnant waters is taken up. And apart from that, to reduce the source reduction, reducing the breeding sites of mosquito, we do use for the larvae of these mosquitoes, we do have larvicidal, or not larvicidal, actually it is the fishes which are called as gambusia. They thrive upon this larvae, they eat upon the larvae. So gambusia is a fish which can also be helpful. So when I talk about control of malaria, as such, no drug is available to destroy the sporozoites before their invasion into the reticuloendothelial cells. So we don't have an effective drug available as of now or today to destroy the sporozoites before their invasion into the reticuloendothelial cells or the blood cells. Okay, and prevent the maturation of or destroy the sporozoites within the infected hepatic cells and prevent erythrocytic invasion. So we don't have drugs to this also, but the prevention and maturation or destruction of sporozoites within the infective hepatic cells and to prevent erythrocytic invasion, we do have drugs like primaquine, pyrimethamine and proguanil. But we don't have any drug available as of today to destroy the sporozoites before their entry into the reticuloendothelial system. Whereas we do have drugs which can prevent the maturation of or destroy the sporozoites within the infected hepatic cells and prevent erythrocytic invasion. The drugs are primaquine, pyrimethamine and proguanil. Primaquine, pyrimethamine and proguanil. Apart from that, we have certain drugs which are called as suppressives. So these suppressives, they actually inhibit the erythrocytic zygogony and prevent the rupture of erythrocytes. So drugs which inhibit erythrocytic zygogony and prevent the rupture of erythrocytes but do not eradicate the infection. They do not eradicate the infection because some of the parasites are also present in the liver. Okay, they are in the liver, they might be elsewhere, but to inhibit the erythrocytic zygogony and prevent the rupture of erythrocytes but not eradicating the infection, the drugs are quinine, chloroquine, mefloquine, artemisinin, proguanil, pyrimethamine and tetracycline. Then for radical cure, where the relapses do not occur, example, the drugs are primaquine and proguanil, but mainly we do use primaquine for radical cure. For radical cure, we use primaquine. Then the gameticidal drugs. When I talk about gameticidal drugs, we do have chloroquine, quinine, artesunate, except in Plasmodium falciparum. So these drugs can be used in all the species except Plasmodium falciparum. Especially, what are these drugs which are used? Gameticidal drugs. They are not used in falciparum but can be used in vivax, malaria and oval, like chloroquine, quinine and artesunate. But whereas primaquine is effective to treat all the species of Plasmodia. Okay. Now with this, I think I will stop my talk here, and I will continue in my subsequent lecture regarding the individual drugs, not all the drugs, but very important drugs and very important salient features, the mechanism of action and so on and so forth. Thank you for patient listening.